the reason for denial was the patient had not done and failed 12 weeks of physical therapy. And I'm like, her humeral head is sitting in her armpit. Like, what physical therapy do you want this lady to do? And so I did the peer-to-peer. I had no choice. And I'm talking to this person who is a retired physician, is not an orthopedic surgeon. And I'm just asking them, like, how are you the peer who's denying this? And I told them very upfront, like, I'm not trying to be rude to you. Like, you're not my peer in this. You've never done a surgery on the shoulder, let alone dealt with a proximal humerus fracture dislocation. How can you even be the person I'm talking to dictate whether this gets approved or not?
Welcome, everyone, and thank you for joining. I'm Zach Ruhl, the co-founder and CEO of Maia, where we've built an AI-powered medical coding and revenue cycle management platform built exclusively for orthopedic practices. Today, I am joined by two exceptional orthopedic surgeons who bring clinical depth and real-world practice experience to the conversation. Dr. Richard Yoon is a fellowship-trained orthopedic surgeon specializing in trauma and adult reconstruction, currently serves as the Director of Orthopedic Research at Jersey City Medical Center. And Dr. Adil Ahmed is a dual fellowship-trained orthopedic surgeon specializing in shoulder, elbow, hand, and nerve surgery at the Baylor College of Medicine in Houston. Thank you, gentlemen, for joining.
Thanks for having us.
Absolutely.
Thanks for having us, man.
Today, we are going to talk about a large problem in healthcare administration. Actually, two large problems. Number one, undercoding.
That's it?
And number two...
Only two?
Only two. We're going to talk about undercoding and about denial appeals and how those affect both your practice and you specifically as expert orthopedic surgeons. Dr. Ahmed, let's start with you. Undercoding is very common. We've found that with a lot of our customers. Can you tell me a little bit about how that's affected you and your practice in the past?
Yeah, I mean, it's a constant thing because, I try to preempt this issue by every time I write an op note, whether I dictate it or I type it, I always, and I've talked to the billers about this, I always place specifically the CPT codes into the op note always. So there's no discrepancy about what the procedure was, if there's any add-on codes, anything like that. Because a lot of these procedures, especially reconstructive surgery, revision arthroplasty, there's often a lot of additional codes, removing prior hardware, nerve releases that are necessary in addition to the actual bulk of the procedure itself. And, the coders, especially large institutions, are traditionally taught to be a little on the conservative side, so-called undercoding, even if higher codes are not only achievable, but also appropriate based off of the surgery that was done. And so that's something that routinely, despite putting them in, I still have to have conversations every couple of weeks with the coders. And a simple example, when I do elbow, for elbow stiffness after traumatic arthritis, post-traumatic contracture releases, there's a lot of different codes that can be done, and it depends on the procedure you do. And very often, a cubital tunnel release, which is a nerve release for numbness in the ulnar digits, which is a very common thing that happens when the elbow is chronically stiff. That is done as a separate thing. It's often a separate incision as well. They very routinely will try to drop that code. Even though it's a distinct code, it doesn't affect any bundling issues. So it's these repetitive conversations, repetitive time investment on my part, on the biller's part, and delay in sending that as a claim. That's just one example, Zach, of undercoding that I deal with often. Even though I try to preempt it, it still isn't a perfect system.
Absolutely. And we see that a lot around many different practices, so that's not necessarily unique to you. Dr. Yoon, can you tell us about how you've experienced these coding discrepancies between you and your coders in the past?
I think in general, there's this stigma and a fear of overcoding, right? Like I have a senior partner who will always code a level 3 for everything, right? I don't think it's for E&M office visits. I don't think it's that uncommon. I bet you in the audience here, if it's not you who's listening, you have someone who's a partner who basically just plays it safe and just builds a 3 all the way through. I think that's one of the biggest kind of myths of coding, especially since the 2020 kind of AMA changes and the RVU changes there. It's no longer on the point system. You really can have the opportunity to maximize your E&M coding. I think that's a lot of undercoding and revenue lost that can be easy to do. The process itself makes it extremely difficult. Denials and kickbacks are very easy. you have one typo, right, left, ICD-10's wrong side, something, automatic kickback. The rate at which you have a successful hit, and even with pre-auth, a lot of the times, I mean, if your lot number on your injections is wrong, it's going to delay you 90 days in collections, right? So you have a successful private practice, you're probably going to run a margin pretty lean. I mean, I'm not even talking about ancillaries, but if you're going to be collecting 40%, that's probably great. Most hospital systems, academic places, if you break 20, 25, it's like a miracle, right? My system is not the best at doing it. There's a lot of money left over on the table for two really ridiculous things. An uncertain percentage, probably 15 to 20%, depending on which data paper you look at, has no nonsense rejections, cited wrong, typo, date of birth wrong, like wrong, sorry. But easy fixes, right? Easy fixes. And that's a big chunk of money. And then there are the ones where, like, you have one of your partners who never got out of residency phase and they book a case and it looks like they're booking the easiest case in the world. But if you try and bill a level 5, your note has to reflect the complexity and the sickness of the patient accordingly, right? Like, I think we're good at it. We're not good at it. We're actually talking about it now. Before we weren't allowed to talk about it, right? Like, God forbid you and I talk about contracts or money or whatever, right? We're like a bad doctor if you talk about money. That's not how it works anymore. I think that when it comes to this, there are a lot of things that are left on the table, and there's a really big opening for an automated way to capture everything that's easy and at the same time not commit fraud. Because remember, to the audience out there, undercoding is also fraud, just as much as overcoding. And honestly, the worst that happens if you try and bill a CPT code and you get rejected is to learn why and understand, even if it means you have to do a peer-to-peer, how to get it before. We've been more successful getting a lot of pre-auth done for a lot of the revision codes. I attribute my boss for doing a lot of that legwork before me. But the small saucerization, open lysis, neuroplastic, right, these little things, it's just an open discussion. A lot of times even the payers will sit down with you, right? So I think communication in general needs to improve, but from our side, there's just a big void in efficiency in getting big chunks of money for a thing that's easy to fix.
Yeah.
If that makes sense.
Yeah, that makes perfect sense. Thank you for sharing that info. Dr. Ahmed, let's talk a little bit about authorizations and how the authorization process and even partial approval for authorizations can cause administrative disruptions for you at Baylor.
Yeah, basically everything needs prior authorization now, and meaning essentially that you have to submit to the insurance companies, to the so-called payers, what you intend to do for the patient, what your treatment is based off your medical decision making, and now they, using their language of payer side, pretending they don't make medical decisions, will either approve or reject it. And what they claim is they're only approving or rejecting the authorization to give you the reimbursement for what you want to do. They obviously won't claim that you can't do the procedure, but now it's between you and the patient to fork up the cash, or you do it without pay. So that's really what the authorization requires. And the headache comes in when an authorization either gets denied outright, or there's a partial denial where, let's say you're doing a rotator cuff, which is done with a scope. And very often in those cases, you're doing something to the rotator cuff, you're doing something to the biceps, and you're doing some type of decompression just of the structures in the joint. And often, just to repair the rotator cuff itself, you need to debride a lot of structures to remove the bursa, get access, prepare the bone, prepare the footprint so that you can actually put the anchors in and repair the cuff. And so invariably, you're going to have at least 2, if not 3 codes in a shoulder scope involving the rotator cuff. And very often, that debridement decompression code will get denied. And so you have one of two options. You can try to fight it ahead of time. You can send an appeal. You can do a peer-to-peer, or you can just drop it ahead of time. You do the case. You're going to end up doing the decompression and debridement because you have to do it in order to see the cuff and repair it appropriately. So then you add on the code after the fact. And now you're kind of on the hook from the payer side. Will you get reimbursed or not? Because it wasn't pre-approved, even though it was justified and you did do it. So that adds a lot of time, it adds a lot of delay, and it adds a question mark about getting reimbursed for something like that. And so that's kind of like just one example of partial approval in this whole pre-auth process, or partial denial, however you want to look at it, versus just outright denial, where something is denied. And now, depending on the payer and depending on the procedure, some cases, like let's talk about shoulder arthroplasty, shoulder replacement, some will be flat out peer-to-peer isn't even an option. You can only write an appeal. Some only peer-to-peer is an option. And so it just depends how the payer wants to do it. But that also adds administrative time, first for your staff, to try to figure out what was denied and why. Do we actually have all the stuff? Did we send the MRI or CT scan of the patient? Did we send the report to them? Oh, we did. The payer just happened to not look at it or didn't care about it. So you can write an appeal like, hey, it actually has this. It shows there's subluxation. It shows there's a V2 glenoid deformity. It needs to be approved. That's not something that's going to get better with physical therapy. So often it's just some little detail like that that's left out or ignored. And then scheduling it, trying to schedule a peer-to-peer. They call you at odd hours. You might be in the OR. You don't even know. It's a number you don't recognize. And then trying to call them back. You wait on answering, you play phone tag with each other. It just wastes a lot of time. And the value of your time monetarily is one thing, but it also distracts you from other patient care that you're doing. You have to step away in clinic. Now, in between clinic patients, you're dealing with a peer-to-peer phone call, pulling up the patient chart, and looking at that. So those are all the administrative headaches and real-time commitment issues with the whole pre-approval denial appeal process.
I want to touch on something and dig in a little bit. The peer-to-peer. I saw recently that your podcast, Two Docs, One Mic, was featured on the New York Times talking about a peer-to-peer denial situation. Could you tell us about that situation?
Yeah. For one, it was very surprising to us that the New York Times found our little podcast that I do with my buddy. My friend, he's a cardiologist. His name's Yoon and Dr. He's in Houston with me as well, and he's a private practice. But yeah, our podcast, Two Docs, One Mic, just kind of randomly, this reporter from the New York Times reached out asking if they could feature a segment on it, which I was discussing this kind of process, a peer-to-peer that I did for a patient who needed a shoulder replacement. And so, a quick backstory, this was like a 70-some-year-old lady who fell and had a really bad fracture dislocation of the proximal humerus. It was a multi-part fracture. The joint was dislocated. And they requested a peer-to-peer. They denied the shoulder replacement, which needed to be done urgently. It's not an elective thing. And the reason for denial, basically they didn't read any of the clinical note. The reason for denial was the patient had not done and failed 12 weeks of physical therapy. Her humeral head is sitting in her armpit. Like, what physical therapy do you want this lady to do? And so I did the peer-to-peer. I had no choice. And I'm talking to this person who is a retired physician, is not an orthopedic surgeon. And I'm just asking them, like, how are you the peer who's denying this? And I told them very upfront, like, I'm not trying to be rude to you. Like, you're not my peer in this. You've never done a surgery on the shoulder, let alone dealt with a proximal humerus fracture dislocation. How can you even be the person I'm talking to dictate whether this gets approved or not? Like, I'm the expert telling you it needs to. You don't have the basis to tell me that I'm wrong. So you have to approve it. Like, that's the end of it. You just need to. And, like, I was firm but polite. And they were just like, yeah, I mean, from what you're telling us, it sounds like it's a pretty bad injury. And they approved it. But it's just a charade of doing that. It was just comical. It was just so stupid. And so that segment of the podcast, like, was what New York Times picked up. And they put it in one of their segments where they were talking about this whole process of basically insurance overstepping and the payer becoming the dictator of care. So, I mean, it was cool from my standpoint, like having my tiny little podcast featured on New York Times. But I think it also shows the importance of highlighting issues like this, that a publication as big as the New York Times was picking this up and understanding this whole backstory, the behind-the-scenes look at the nonsense that is dealt with from the physician, but also the patient in getting insurance to approve an appropriate treatment for care.
Yeah, that is, I mean, we laugh about it a little bit. We shouldn't, right? Because it's so ridiculous that PT could somehow fix that injury. But I think it's important that you're bringing it to light. Dr. Yoon, let's transition to talking about the future state of how these issues can be addressed. Of course, you're a very well-respected trauma surgeon, but I've also seen you featured many times talking about medical coding and how that affects physicians and practices. Because as another one of your peers put it in a prior webinar, your margin fuels your mission, right? I mean, we need to talk about these things because it fuels all the great work that you're doing in the operating room and in the clinic. How are you seeing technology and other future tools impacting your medical coding processes, your denial appeals, and really all the revenue cycle as we move forward?
I think that, especially for the new practitioners that are coming on board, the recent graduates and whatnot, technology is not going away. Your ability to document and your ability to be at a zero charge lag, so to speak, as a physician is not going to go away. When we're residents, our case logs are really bad. We're really bad at writing notes and all this stuff. But if you want to be a successful attending surgeon that does good work but also gets compensated for it, you have to hit certain metrics that make it so that you are not a problem employee, right? Like if you're the person who closes out all the charts and has your billing done and your notes done every day, no one's going to ever question whether or not you are up and up on what you have to do, right? You have to be professional in that regard. That being said, if you do that at baseline, then you jump into another part of your practice where you understand the business of medicine and you end up kind of being not necessarily a leader for your group, but understand that your power comes in the revenue you generate, whether you're in academia or not, and understanding how much revenue you generate as a group individually, including your downstream impact that you have for the system or practice that you're a part of, is a very, very powerful knowledge base to have. And the really only way to do that is to have buy-in from everyone in the department, right? Everyone has to be good soldiers. They have to do what they have to do. Because when I need to talk to someone about why I need something or why we need to maneuver in a way, I have to say that, hey, look, this is how much money we make for you, right? On that regard. At the very baseline, there are so many things that are low-hanging fruit. E&M coding, how many visits a day? I have 2 office days a week, one in location. I see 70 to 80 patients in one day. I have a lot of help. I have a big system. I'm usually done by 3:30. I'm closed out. I'm like done with everything when I leave. I maximize, for me, in my calculations for my contract, I probably hit, with this contract, my previous contract, it was higher, way higher, but now I probably hit 75 to 80% of my RVUs with office RVUs alone, right, in order to hit my productivity. My surgery after that kind of takes care of everything else. If you're a practitioner, you have to understand where this comes from, and then the automation that's necessary makes the collection process much more reliable, and in that way, your power grows, right? If everyone's making more money because things that are taken for granted are taken care of immediately, you're automatically probably looking at an additional $2 to $5 million a year, depending on your volume, just based on getting rid of those little stupid error appeals, right? And that money can cycle back and do whatever you want, but like, then you can start talking about getting rid of, understanding the billing and coding part of it, making that part efficient, and then parsing down your departments to make that more efficient. Or directing those departments into things that are more specific, long-term appeals, more complex cases, where you might not necessarily have the time or personnel to dedicate now, But because you have an automated system taking care of the easy stuff, maybe this team, you don't have to fire them, but they can actually go get the big money tickets that are on appeal for like, 3 years or something, the cold cases or whatnot.
Right.
I don't know. But, automation to hit the low-lying fruit, the payers are already using it anyway. That's why that case gets denied, right? You have someone who sent probably like an inappropriate ICD-10 code that has arthritis in it, and all of a sudden they're like, we got to deny it because it's a shoulder arthroplasty instead of a fracture code, right?
Right, right.
It's stupid, right? But that should have been picked up, corrected, sent out.
Right.
So you can minimize that effort too.
Yep.
Right? That's the beauty of AI now. You can have these filters that continue to learn depending on region. We know that's different, right? Where you can have this thing improve over time and really just prevent those little errors and relieve headache. And that's where I think the future's going.
Agreed. Yeah, I think technology can certainly catch errors prior to cases going out to the payer to avoid those preventable denials, and can overall improve the administrative efficiency and take out friction at the same time. Dr. Ahmed, curious your perspective on the future of medical coding and denial appeal management and how you think that can impact you in your practice.
I'll piggyback off of what Richard said just a moment ago. I mean, the automation and using this technology for it, I think, is really the most logical way. I mean, for one, the technology doesn't sleep. The technology doesn't clock in and clock out, right? You have AI tools, AI agents, a real software system that adapts and learns and has a repository of experience, right? Just from data that's been fed into it, and it learns even more over time as it sees more and it does more. I mean, it constantly will pick stuff up, and it'll pick stuff up in real time. You're not waiting to write your note, hit the sign button, then it goes to a human who kind of reads it, kind of doesn't, and invariably is going to miss stuff. And so that's one thing. I mean, just the automation, the more rapid ability of it to do it, offloads your payroll, so you can open up money and revenue for other things. And then in terms of the coding itself, not only just the preempting part of it, but once a surgery is performed, you may not always do the same thing. I mean, especially Richard can probably speak even more to this in the world of trauma. A lot of the cases, not all, but a lot of the cases, you kind of find out what you're going to do when you get in there. You have an idea, but not everything you're going to know exactly. It's going to be XYZ code, and that's it. It's not always like an elective case. So in those settings, you dictate the op node, and sometimes you may not even be aware that you're undercoding, overcoding, or just inappropriately coding something. Not everyone is a wizard with coding. There are thousands of CPT codes, and then not just the codes, the modifiers, all of these different factors at play that no one human can do perfectly. And even if you're good, it takes a lot of time. So in the same way that it could preempt stuff and avoid issues going in, at the point of care, basically what I'm talking about in terms of data, the op note, it could look at that and give you suggestions in real time. And then even after the fact, if there is a denial or there is a partial payment or partial reimbursement and you need to do the appeal process, it can automatically pull the data rather than now you sitting there opening up your electronic health record, combing through the chart, and then the MRI or CT scan reports, the lab value, pulling everything together yourself and codifying it into a letter. I mean, it can basically give you at minimum the skeleton of that entire appeal for you just by combing the same thing you would have done with your eyes and taken more time. And then you can edit it as you see fit. But I mean, these things are already all possible to some extent. And I think the technology is continuing to grow. We see advances in AI. Literally, it's not even like month by month, it's week to week, day to day. So I think it's something that's just ripe for explosion. I think it's going to be huge.
I love it. Thank you for that perspective. Gentlemen, I want to thank you both for joining. It's a pleasure to have two distinguished surgeons like yourselves joining to talk about this very important topic. Thank you, Dr. Yoon. Thank you, Dr. Ahmed. It was great to speak with both of you today.
It was a pleasure. Thank you, Zach.
Thank you.
A lot of fun.